Research Innovation Conference. First of all is Dr. Bredenberg, who is a hospitalist and board certified in addiction medicine at the University of Colorado Hospital. She is a surgical subspecialist, and she's currently enrolled in the SCORE Fellowship. So that's, if anyone hasn't heard about SCORE and is interested in outcomes research, this is a really important fellowship that you should be looking out for calls for application for. It's a wonderful program. And the research that Dr. Bredenberg is about to present will show that. She has research and clinical interest in the impact of housing insecurity around hospitalizations. And with that, I'll pass the time over to Dr. Bredenberg. Thank you.
All right, great. Well, thanks so much for having me. I just want to say, even though I am in the SCORE Fellowship, I'm not a surgeon. I am a hospital medicine provider and addiction provider at the University Hospital. And I'm excited to talk with you all about the expansion of treatment of hepatitis C among people with substance use disorders. Just something in conflict of interest, this work is partially funded through a SEPS grant. And I have no conflicts of interest to disclose. I do want to say that as a hospital medicine provider and I am coming at this from the perspective of a generalist and an addiction provider. I'm not a virologist, I'm not a hepatologist, but just interested in expanding with evidence-based treatment to high-risk populations. So a little bit of background on the hepatitis C virus. Almost 60 million people are infected worldwide, with about 2.5 million of those in the United States and 36,000 in Colorado. There's a major burden of morbidity and mortality worldwide, most deaths from complications of cirrhosis or hepatocellular carcinoma. And because of this, the World Health Organization has prioritized treatment of hepatitis C virus and set a goal of eliminating viral hepatitis as a public health threat by the year 2030. So the title of this talk is about treatment of hepatitis C. So just talking a little bit about treatment. Highly effective, direct-acting antiviral medications have been on the market since about 2013. These are very effective with a greater than 95% cure rate, generally well tolerated, and as you can see from the little table below, are also expensive medications. So these are the list prices. This is not a complete list, but just kind of some examples of common regimens that are used. Obviously, this is not the price that most of our patients are paying, but I think it's worth mentioning it. You know, while these have recently been shown to be cost-effective medications, and even in some analyses cost savings, they are have a pretty high upfront cost. I also want to highlight that in recent years, subspecialty organizations have outlined simplified treatment regimens. You know, initially treating hepatitis C was kind of in the purview of infectious disease doctors and hepatologists, but in order to meet this goal of eliminating hepatitis C as a public health, there have been efforts to expand treatment to people who are not knowledgeable necessarily about the hepatitis C virus, but to be accessible to a broad range of people in the healthcare workforce. That includes, you know, primary care physicians, pharmacists, or others who might not be subspecialists. Just to highlight a couple of society guidelines. So universal screening for hepatitis C is now recommended for all adults. That's a one-time screening in a lifetime. And then people who are at higher risk, which includes people who use drugs intravenously, should be screened more often, so at least annually, as long as they're at higher risk. And there are also recommendations that screening should be embedded in other healthcare services. So really, again, expanding access to treatment by expanding the population that we're identifying as having this disease. And guidelines also recommend offering treatment to all patients, specifically including those with active substance use. So that should not be a barrier to treatment for patients with substance use disorders. A little bit of data as to why that is. So rates of cure in people who inject drugs are high. Some studies have shown that they are equivalent to people who are not injecting drugs, but some studies have shown that outcomes are not as good. It just depends. But even the studies that show outcomes are less than people who are not actively using substances, still a greater than 90% cure rate. So very high cure rate. And then reinfection rates among people who inject drugs are low. And so because of that, I think that feeds into those recommendations that everyone deserves to be treated for this very now treatable disease. I do want to point out that access to treatment in people with substance use disorders is limited in some states. So 19 state Medicaid programs continue to have sobriety requirements, and that means that patients either have to demonstrate that they have not used any substances for 6 to 12 months. In some states, it's less stringent. They just have to be counseled and referred to treatment, but some kind of limitation on access to prescribing these medications to the Medicaid population. I will say Colorado Medicaid lifted these requirements in 2017, and actually in organizations that monitor this, Colorado gets an A+ for access to these medications, which is really great. And so this is a really interesting website, the State of Hep C, that just, you can go to any state and find out kind of what are some of the barriers among the Medicaid population. But we're doing really well from that standpoint. I want to point out, this is just a diagram of the treatment hepatitis C virus care cascade. So this is global, and these are data from 2015. So, the exact numbers are not necessarily applicable to the specific population that we're seeing in Colorado, and specifically at, like the university hospital, but just pointing out where people are lost along this treatment cascade. So a big drop off from infected to diagnosed, then to treated, and then to cured. People are obviously lost at every step along the way. So something to keep in mind as I talk through some of the interventions and how to increase the uptake of this treatment. So the specific clinical question that I'll be talking about, like I said, I'm a hospital-based provider, so I'm interested in how do you use the time of hospitalization to increase uptake of screening and treatment of hepatitis C, specifically among the high-risk subset of people with substance use disorders. And the title of the talk is on treatment, but, as delving further into this, I think screening inevitably becomes a part of that, because if you don't identify people, you can't treat them. So I'll mostly be talking about treatment, but a little bit about how to potentially expand screening as well. A little bit of preliminary data. So this is from 2022 at the University of Colorado Hospital. So 1,076 patients with a diagnosis of hepatitis C were hospitalized at the university last year. And that was for a total of 1,700 hospitalizations. Obviously, some folks are very sick, are hospitalized multiple times. I want to point out how we got this data. So we looked at both people who had a reactive antibody test indicating that they have a diagnosis of hepatitis C, and we also looked at people who have a diagnosis code alone, and we pulled both of those to make a total. So just pointing out, about half of the people who were hospitalized with a diagnosis of hepatitis C, they had both in the system. A small number only had a reactive antibody test and had no kind of diagnosis anywhere in the chart of hepatitis C. But then there's this subset of people who only had a diagnosis code and no sort of test confirming this. Doing some manual chart review, it looks like that's probably because people are mostly getting tested at outside facilities. So when you actually go into the chart, you verify if it's an accurate diagnosis, it seems to be pretty accurate. So I think this is probably the best way to capture this population, is looking at both of these measures. So then, of those people, how many are eligible for treatment of their hepatitis C? So of people we know of, the answer would be 232. So that is the number of people who had a documented elevated viral load indicating that they have active hepatitis C. 542 had a negative PCR viral load, suggesting that they either have spontaneously cleared their hepatitis C virus or they've been successfully treated. But then there's almost a third of patients who we don't know their viral status. And I think there's an opportunity there. These are people who are potentially getting lost along that cascade of care. So probably some of those people, again, they just have gotten testing at other facilities, and they've either been treated or they're plugged into care elsewhere. But I suspect that a number of those people just were never tested to find out if their hepatitis C is active. So opportunity for improvement in the future. So that's kind of the lay of the land. At least 232 people a year are hospitalized at the University of Colorado Hospital with active hepatitis C, potentially eligible. So what intervention? Why not start people on treatment while they're hospitalized? I think the potential benefits here are kind of obvious as we talk about, the recommendations. Everybody should be treated. Expanding treatment to kind of community care sites. I would argue that you can include in acute care hospitalization. If we're capturing people, we should start them on treatment. And so we've been doing this, which is great. So Dr. Sarah Scher of infectious disease and Robin Bricker-Ford, who's the hepatology pharmacist at the university, put together this pathway in 2019 and started getting people started on treatment during their hospital stay. So this is sort of a brief overview of what this process looks like right now. A provider would identify somebody that's appropriate. Generally, these are people who would fall into that sort of like treatment algorithm, the simplified treatment algorithms that I mentioned earlier that have been put forward by the various societies that are really intended to expand care to a specific subset of people with hepatitis C who have uncomplicated disease. So they're treatment naive, they don't have hepatocellular carcinoma, they don't have decompensated cirrhosis, and then for the purposes of this pathway, people who are going to be in the hospital for greater than a week just to allow time for prior authorization and getting people started on treatment, doing appropriate counseling, et cetera, et cetera. Well, that's not necessarily hard and fast, that's kind of how things have been done. Provider notifies the pharmacy team and kind of discusses, is there any additional treatment that needs to happen? Pharmacy group can recommend any necessary follow-up testing that hasn't been done, obtains prior authorization, recommends treatment regimens based on, again, loosely on those simplified algorithms. The medication, these are not on formulary medications, they're specialty medications, so they're sent to the outpatient pharmacy, brought over to the hospital, and dispensed in an inpatient setting. And then when the patient is discharged, they go home with a portion of that treatment course in hand. So if they have gotten 2 weeks of treatment in the hospital, they'll go home with another 2 weeks, and then they'll need a refill to complete 8 weeks of treatment if they're on an 8-week treatment course. If they've been in the hospital for 6 weeks, they'll basically go home with the remainder of the treatment course if they're on an 8-week treatment program. And outpatient follow-up is arranged. So, to date, that has mainly been kind of owned by the infectious disease department at the university hospital. So the intervention that I've been trying to work on is kind of building on the work that Sarah and Robin have done and just expand the pool of inpatient physicians who start this treatment. Because again, those simplified algorithms are meant to be there to expand treatment to people who aren't necessarily super involved in the prescribing of medication for hepatitis C. We have really robust pharmacy support, and it's honestly a lot to ask for infectious disease to have to own this process. They're always unbelievably busy, so why not expand this to other services? So to start with, we looked into expanding this to the addiction medicine service because it seems like kind of a natural fit. Addiction is seeing a lot of people that are high risk for hepatitis C, and they're capturing, potentially people who aren't necessarily being seen by the infectious disease conflict service as well. So we put together a survey to send out to our addiction medicine consult providers. And just to kind of as background, all of our addiction medicine consult service providers are hospital medicine providers. It's entirely staffed by hospital medicine physicians and APPs, in addition to our social work care management team. But some of whom are now board certified in addiction medicine, practice pathway, including myself. So, 11 people answered our survey, 6 physicians, 5 advanced practice providers. And I just want to point out that no provider had ever personally prescribed these medications to treat hepatitis C. So these are just a few of the results. There were a lot more questions, but sort of the gist of it was that people on the addiction service, they do not feel personally comfortable with these medications. They don't know what the interactions are. They don't know how to identify people who are appropriate for treatment. But they like the idea, in theory, of starting these medications in the hospital. So you can kind of see on the left are 2 questions. I know how to identify appropriate patients. I know where to get interactions. Mostly strongly disagree with those. And then I like the idea of starting direct-acting antiviral medicines to treat hepatitis C. Most people agreed with that. And so that was kind of seen throughout most of the questions that we asked. So theoretically, a good idea, but people don't necessarily feel they have the knowledge base to do this. So that's some kind of preliminary data, and I will talk more about kind of how things are going in a little bit, but a little bit more preliminary and background data. So in addition to internal efforts to try to expand this among addiction medicine providers at the University Hospital, we're also conducting a qualitative interview to kind of understand across the country what are the perspectives of inpatient subspecialty providers? Is this something that can be kind of expanded on a national level at different institutions? And I should also mention that we're not the only institution that's doing this. So OHSU, UNC, UPenn, UCSF, those are 4 institutions that I know of that are also have different pathways to get people started on treatment in the hospital. So I'm really interested in finding out what are the perspectives of people who have a special interest in treating hepatitis C with respect to this kind of starting people on treatment in the hospital. And so we're interviewing hepatology providers, infectious disease providers, and addiction providers who work at least part of the time in an inpatient setting. Very preliminary thus far. I've interviewed 2 addiction providers and that's it. So I don't have a lot of preliminary data to show you or really anything, but I'm going to roll that in with the next thing I'll talk about, which is some quality improvement review of UCH patient charts. Because I think already just with these few interviews and the review of patient charts, there's a couple of things that are coming out with respect to this process that might be barriers. So over 50 people have undergone this process in the hospital at University of Colorado since this was started, and I've gone through about 20 of those charts and sort of combining these very preliminary qualitative results in that chart review. These are some of the barriers that are coming out to this implementation. So to start with, the subset of people with substance use disorders experiencing hospitalization is a very sick population. So not necessarily comparable to studies that have been done before on people with substance use disorders, because in general, these are people who have severe substance use disorders. They're often being hospitalized with consequences of substance use, sometimes multiple times. So it's a very sick and very complex population. So I think that's one thing to point out. So, concerns about these, again, are expensive medications, and are the outcomes going to be equivalent to what we've shown before, or are these people who are at risk of poor outcomes because they might be lost to follow-up? And then risk of resistance. If people don't complete their treatment course, is there a risk of resistance to these medications? That's one concern that's come out. And then sort of similarly to the survey of addiction medicine providers, concerns about how do you identify people who are appropriate for this intervention. So, I think there's an argument to be made for everybody. Everybody is appropriate for this intervention. The guidelines say substance use should not be a barrier to treatment. If we know people have hepatitis C, we should just start them on treatment as soon as possible. But I also think that has to be balanced against what I just said, that this is a particularly sick and complex population. So I think this is not going to be an easy question to answer, but I think this is one concern coming out is if we're expanding this treatment for people who are not as familiar with hepatitis C treatment, how do we make sure people know who's appropriate for this intervention? And I don't think there's necessarily an easy answer here. And then concerns about how to ensure linkage to follow-up care, I would say, again, kind of plays into the prior concerns that I just mentioned. So that's kind of where things are in terms of preliminary data and where things stand in terms of this intervention at the University Hospital. So that kind of leads into where are some opportunities for improvement. So I just want to point out the goal of these interventions is to get people treated and cured of their hepatitis C. So that means reducing the number of people who are lost along that cascade of care. So making sure people have a screening antibody test and a viral load. If the antibody test is positive, initiating treatment and completing treatment to a test of cure. And I think there are opportunities for improvement pretty much at every step along this pathway. So the data that I showed you before, we really haven't delved into, who's not getting screened, which I think in part because that's a very difficult question to answer, but there's certainly an argument to be made that potentially we should be universally screening everybody who comes in the hospital doors. There's also an argument to be made that, a lot of people can get screened at their primary care doctor's office. The recommended screening is once in a lifetime. And so are we really duplicating tests unnecessarily with the goal of picking up on people who may not be getting their recommended screening? So again, no easy answer there, but I think at least expanding screening and ensuring that there's some way built into the system of ensuring that people who are at especially high risk, who fall under that should be getting annual screening, are getting screened when they come into the hospital. I already touched a little bit about looking through the data a little bit more to find out why some people are getting lost on that screening antibody test to viral load, and then obviously that viral load to initiation of treatment questions still there. Again, opportunities for improvement at pretty much every step along the way. Another opportunity for improvement is if we're going to expand this to other providers, we need to support providers who might not be familiar with these treatments. And that's what the guidelines are designed to do. And we already have an incredibly robust pharmacy support that's very familiar with these treatments. But that's not something that a lot of our inpatient providers are aware of. And so figuring out how to support providers to identify patients appropriately and then refer them and get support from the people who do know more about this. And then supporting people at a higher risk of complications. There's a lot of preliminary work out there about expanding hepatitis treatment in the community. Dr. Rowan at Denver Health is working on, is treating people at the Harm Reduction Action Center. So already moving into the community space and figuring out how to support people there. So is there a way for us in the hospital to get people into care and then partner with our community partners to ensure that people are getting the support they need when they leave the hospital? Because again, it's a sick population and a complicated population. So next steps, kind of what I just said is identifying why are people getting lost along this cascade of care and then developing interventions to increase screening. So that could be an order set for addiction providers to use anytime they see a patient who's in that high risk category. You use the order set, it comes with a hepatitis C screening. Ensuring that there's a BPA. People are started on treatment in the hospital. One thing that came up in the chart reviews is sometimes people are getting lost to follow-up, but they're having other touches with the healthcare system. They're coming back into the emergency room, they're showing up at their outpatient, eye clinic appointment, but they're not coming back in to get those labs. So is there a way to fire a BPA that says this person really needs to come back in and get their labs and get plugged back into care so that other providers are aware? Just some preliminary thoughts, but I think there are ways to potentially build this into the system to increase screening for hepatitis C among high-risk groups. And it's just going to take some more data to figure out what that best process looks like. So I talked a little bit about efforts to expand to the addiction medicine group, and one thing that came up is that the numbers are pretty small. I think, and it's a busy service, and people are getting lost, and they're still not getting plugged into care. So one thing that is currently in process with Dr. Ruchman, a resident physician, and Sarah Scarpito, who's a hospital medicine physician, is creating an EPIC-based pathway for starting treatment of hepatitis C. So that procedure protocol pathway that I showed you before, that exists on like a PDF, and some people know about it. It's not hardwired into the system anywhere, but this is in process to turn it into an EPIC-based pathway that anybody could access. I imagine there will need to be a lot of provider education, and guys, I'm a hospital medicine provider. I think hospital medicine is a great place to expand this because you take care of a lot of people with hepatitis C, and you're seeing them from start to finish of their hospital stay. So there's opportunities for intervention there, but people can't do it if they don't know about it and they don't know where to reach out for support. So doing some provider education is definitely going to have to be a piece of that. And then obviously we're going to continue these qualitative interviews with people across the country to try to identify what's working at other institutions, what are barriers at other institutions, how can we apply that here, and potentially scale these interventions or be a model for other institutions to do this process as well. And then, like I mentioned before, exploring interventions to support people post-hospitalizations. I think there's not an easy answer, but I do think partnering with community sites, methadone clinics, harm reduction, there are places that people go, and going back to the guidelines and the recommendations that I initially talked about, it's recommended that these be integrated, that screening is integrated in the community sites, so why not integrate treatment into community sites as well, because obviously that's the ultimate goal of expanding these interventions. So that's kind of where things stand right now. Again, a lot of kind of moving parts right now and a lot of preliminary data. Just want to obviously thank Robin and Sarah, and then Eric Graham of our hospital medicine data dream team has pulled a lot of the hepatitis C data and done a lot of work pulling that as well. And then a whole list of other people who have been really supportive for this project.
Dr. Bredenberg, I have two questions. The first one is with respect to Hep C screening. Have you spoken with not pharmacies, like the lab people to see if they could just do reflex for a quant?
I did. So they said it's two different tubes, and they also are concerned about just having everything reflex because they don't want unnecessary lab testing. So I think in the outpatient setting, that's what's recommended. You don't want somebody to have to come back twice. It's a little bit different in the inpatient setting. It's a little bit harder to, I think, balance that, sort of like you want people to get that next step, but you don't want, everybody, you don't want to over test. So I have spoken with them about it. Those are the barriers right now. And I've sort of been thinking about something like a BPA, but I don't know of any other examples in the lab where that is the case. So, yeah.
And then the second question is, what does the literature say about patients that don't come in for that, whatever, 3 or 4 week lab check? What if you just get them 8 weeks of meds? Those medicines are so effective that you can miss a decent amount of doses and still be cured. And so what does the literature say about that with respect to getting people cured at the expense of maybe not getting labs at midpoint?
I think a lot is still really unknown because I think there's data that shows even with lower adherence rates, people using substances have very good clearance rates. And just totally talking to people at other places, I was talking with somebody at UNC who is doing this, and they said, they had somebody who received a week of medications, and they had like a catastrophic hospital stay. They couldn't get any more. They cleared their lives. So I think there's a lot that's unknown about, what is the optimal duration of treatment? Is it possible to treat people shorter? And then, what if we just give people the whole course of medications? I think, lots just unknown.
Do you know Lauren Nephew? So she was, ironically, our grand round speaker yesterday morning, and she's having a lot of the same struggles you are, trying to eradicate HCV on the Cherokee Nation in Oklahoma. So she's at the University of Indiana. So it's almost a parallel program.
Wonderful. Someone to connect with.
Yeah, Dr. Lauren Nephew.
Okay, perfect. Thank you.
Can I ask one more question before we move on? So for the people that have been through your pathway so far, do you know what the follow-up rate is for those people?
No, and like I said, I've gone through about 20 to 25 scars, and so that's one of the things that I'm trying to track is, demographics, do they have a substance use disorder, who referred them for treatment, which as far as almost universally been infectious disease, what clinic do they follow up in, which has mostly been infectious disease, did they follow up in clinic, did they get another viral load, and then did they demonstrate, their sustained viral response at 12 weeks. So those are all things in this spreadsheet, but I don't have that data yet.
All right, thank you very much.